Welcome back. I hope you had a chance to re-energise and make some connections with other audience members. Next up, our construction and refurbishment panel. With an ever-growing UK population and increased pressure on the NHS as a result of the pandemic, it's never been more important to ensure that healthcare spaces meet demands on the services. These facilities include new hospitals and health centres, to name a few. Construction work and refurbishments are needed to NHS estates to ensure the spaces are fit for purpose, so ultimately the highest quality of care can be delivered to patients. This panel discussion will look at how our healthcare system can provide better and more affordable healthcare environments, which are aligned with evolving clinical service and local healthcare needs. We'll also explore how renovated spaces allow clinicians to focus on patient care with a more efficient approach. To look at these areas, I'm delighted to have with me Iain Greggor, Director of Estates and Facilities at Berkshire Healthcare NHS Foundation Trust, Duane, Acute Redevelopment Programme Director for West Hertfordshire Hospitals NHS Trust, Martin, Estates Director, North East London NHS Foundation Trust, Ian Smith, Head of Construction, NHS Property Services Limited, and David Martin, Vice President of Stantec. Remember, this is a perfect opportunity for you to ask any questions you may have of our panelists by using the live Q&A chat feature, which you'll find on the right-hand side of your screen. So please don't be shy. I like to think of these panels and a conversation with you, very much part of that conversation. So do put your questions across. So good morning to you, gentlemen. How are you all? Good?
Morning.
Thank you. Morning.
David, if we may start off with you, has the pandemic, do you think, provided any positive disruption as we plan and design acute hospitals to enhance patient care and patient experience?
Well, that's a that's a good, very good question, Helen. If you'd asked me that question about a year ago or 2 years ago, before the pandemic hit us, we would have been designing most of our spaces in I think quite a traditional way. There would have still been space for infectious diseases in a number of different hospitals, and certainly in the project I worked on before this, we did have a quite extensive infectious diseases unit with positive and negative pressure for control of infection. If you'd asked me 18 months ago, when I first started at West Hertfordshire, we were really then in the midst of the pandemic. Particularly our trust was one of the first ones that was hit by the issue with oxygen supply, because the amount of oxygen that needed to be supplied onto the wards was outstripping the capacity of the oxygen cylinders on site, and also freezing up as well. So we were one of the first hospitals to encounter that issue. So I think on that infrastructural point, making sure that we've got the capacity and resilience across our estates to meet future demand for more oxygen. So that's been an interesting challenge for us in how we plan that into the redevelopment of our main acute site in Watford. Then from that, it's control of infection obviously has always been in the NHS a really key point for us. And certainly one of the challenges we have in Watford in particular, which is that our mostly acute bed base, is the number of 6-bed bays we have, where the beds are still quite close together because those are 1960s, 1970s buildings. And so what we're looking at as part of our redevelopment plans is a minimum of 4-bed bays, which is what you'd actually expect from the 1980s onwards, with better spacing between the beds and an increased number of single rooms, which will also go to the patient experience as well. The other point is around that we've slightly changed our approach on, is around donning and doffing of PPE, personal protective equipment, because what we're looking at in the future for pandemic control or an infectious disease outbreak is how you cohort patients onto an individual ward. So rather than donning and doffing before you go into an individual room or into a bed bay, you're donning or doffing your PPE before you go onto the ward. So that's been a a slight change in how we were looking to design our new facilities from about a year ago. So cohorting patients, having more donning and doffing, increased number of single rooms, but also really, really importantly for the staff experience, making sure that they've got space for downtime. So it's ensuring that we do have really, really good staff changing facilities and staff restrooms as well, where staff can just get away for a little bit and down their tools and just recover from the experience that they've just had on their shift. And that's one of the things that's always been kind of designed out or lost in hospital developments in the past.
Duane, thank you so much. That was a very good way to open. David, we've got you now. We started off, actually, my original question was going to be aimed at you about positive disruption. And I don't think I'd quite got you sound-wise. So do you want to pick up on that? Duane was talking about positive disruption and, you know, how we plan and design acute hospitals to enhance patient care. Has the pandemic, you know, helped in a positive way with that?
Absolutely. Can you hear me okay?
Yeah, there's a bit of like shush in the background, but I think we can...
just having disastrous IT issues this morning, so my apologies.
We've had a carpet fitted in the background of panel 1, so carry on. As long as you talk loud and clear, we'll be fine.
Well, that's a really interesting question. Obviously, the hospitals have been under so much stress in the past couple of years, coping with the pandemic, and we have been providing support to hospitals who are trying to undergo short-term changes to cope, but also working on new hospital designs. And a couple things that have come out of the pandemic that are seemingly positive, if I can say it that way, are an enhanced ability to collaborate with staff and work with them in a way that's much more inclusive, it's much more convenient. We feel like we're bringing more people to the table to get their input as we formulate particularly important our planning decisions toward Duane's points about how staff are engaging with the patients, how the patients are experiencing the hospital, and so we find that collaboration is really critical to success, and it's been enhanced during the pandemic in some ways. The other thing we've noticed is that because most hospitals have taken the view, as have people like me, I'm an architect, to have some level of working at home, that there's an opportunity to maybe rethink about provision for corporate services, administrative components, things that are not actually mission critical to the care being provided. And can that have an overall result of frankly reducing the stress that the hospital is under during normal operations? I was intrigued by Dr. Matthew, who had some really fascinating information about the reduction of energy consumption during the Christmas period. And, I would suggest that probably extends to all aspects of the hospital being less stressed during the Christmas period. And I know it's not practical, but can we learn from the pandemic and maybe reduce to the absolute minimum emergency requirements and traumatic requirements within the healthcare environment itself and try to jettison all outpatient facilities, things that are not central to the acute experience, and reduce the overall stress in the hospital. But certainly within administrative components, we are certainly seeing that there is an opportunity there. We're also seeing that a couple of physicians that I know, they might not like it entirely, having all of the consultation done by video conference. Everything is done by Zoom now. But I have heard anecdotally that the number of no-shows to appointments are radically down, because the typical excuses or barriers to people coming to appointments are effectively removed because of this enhanced convenience. And that certainly has to have a positive benefit on the care being provided.
We've got two Ians, so let's bring Iain Greggor into or Berkshire Iain, as I've affectionately called him on my notes, into the conversation. I'm just wondering if you give us a sense, Iain, as what it's been like in Berkshire over the last 18 months. And following on from what everybody else has said, has this given you more opportunity to work with and engage with staff? And what are the positives that have come out of it for you? I always like to look at the pandemic in terms of positives because it has been full of learnings, hasn't it? And it's very easy to be deeply depressed by the whole thing, but some good stuff has come out of it too.
Oh, I completely agree. And, some challenges day on day. I'm trying to reopen a number of mass vaccine centres at the moment today, and we hope to go back live Monday, following the Prime Minister's announcement around the booster and the offer to all over 18s by 31st of December. So the challenges keep on going. I think something I would like to pay particular tribute to is the way that staff have grabbed at the huge challenge that they've had, be they clinical and non-clinical. We do hear a great deal, quite rightly, about our clinical colleagues, but I think back to my estates and FM teams who have really thought through not just the difficulties that COVID brings and all the associated issues, but the benefits. And they've really taken that opportunity to have a look at things like design. How can we make areas easier to clean? Simple things like getting rid of acute corners and moving to rounded corners, getting rid of high dust traps. So relatively simple things like that, but also embracing new technology. And we're thinking very hard, for example, about having many more sensors to help us with air quality. Temperature, CO2 levels, and so on. And we know all of that is really key. As a community and mental health trust, we've had some really slightly different ones from our acute colleagues. I'm thinking particularly of the difficulty of working in mental health inpatient units, where obviously we don't have the opportunity to open doors and windows, but we've really then thought hard about we ensure that both patients and staff can remain in a really nice, pleasant environment, how we could introduce air conditioning and so on into particular areas to at least give folk a relief room, if you like, that they can go into, but also things like uniforms. Just thinking about other different materials, different ways of dressing that we can help keep people cool. But it's then moved on to even things like external environments, because we've had to think about them in quite a different way, ensuring that people have got greater, easier access, whilst of course maintaining their safety and privacy and dignity and so on, to get out into the open area. So it's been, I think it's a huge challenge, of course, but I think the spirit of can do has really shone through at an operational level so much, where people have really sought to work in teams that perhaps we haven't seen before, crossing all sorts of divides, clinical, non-clinical, management, technical, and so on, to really think through problems perhaps in the most crystallised way that I've ever known in 20 odd years in the NHS.
That's really, really nice to hear, and nice as well that you pay tribute to the staff. It's been such a stressful time, hasn't it? And everybody's worked so hard. So if we move to Iain Smith, Iain with an I, what would you say, Iain, has been your biggest takeaway from a construction point of view from the last 18 months?
Yeah, thank you. Well, really, just picking up on the other Iain's point, now I was going to make this probably my first comment was over the last 18 months, we understand it's been so disruptive to all in the NHS, and the fact that we've been able through the relationships and the flexibility of the NHS staff and the trusts, etc. We've managed to continue to work in these the buildings, maintaining, repairing, providing capital projects in a safe and compliant way, ensuring that we don't disrupt any of the work that's going on in the hospitals and the health centres. And that's been a great demonstration of teamwork, and what we've been doing has been critical to maintaining and providing the right accommodation and the right services for our customers. So that's been a really positive thing, and at the same time being able to work in areas where there's a lot of other stuff going on and not disrupting the operations of the health service.
Absolutely.
Yeah, so that was my. I think that's what I've taken away from this last 18 months.
Well, last but certainly not least, hello, Martin. I haven't forgotten you there. What's the impact of COVID-19 had in terms of shaping the future of our new buildings?
So I think that there's two levels for me. The first is internally inside an organisation. You know, all the things that Iain from Berkshire mentioned. You know, in terms of a community and mental health trust, is those things around making it broader access. We started to think now about how we use the building, but how we move not just inside the building, but how access is controlled. So different entrances, different exits, and because we're moving into integrated care systems, we're starting to work closer with our organisations. So buildings become a bit more multifaceted. Just sitting with one will be shared across a range of different partners. So in that design concept, we're thinking about bringing in primary care into buildings, but we'll also have community services, health services. And I think we've now broadened our approach, thinking that we need to think how people gain access, where those buildings are positioned, because place-based care makes is a big impact now. We've seen that where vaccine centres are located in town centres, the footfall is much better and it's much more accessible for service users to get there. So outside of the design, where they're placed become, but I think buildings are now becoming far more multifaceted and working in a closer partnership with other organisations. So it's not just an insular design from one particular trust, that's been spread out across all of the partners we use. And that's to try and support out of hospital care, so we can get people well again in the community, avoiding rocking up to A&E or being admitted. So the development of buildings, I think, are far more collaborative, and I think ICS will play a big impact in how we shape the construction of our of new buildings and indeed the way they're refurbished.
Duane, let's move back to you, if we may. The new hospital programme is a 10 plus year programme as currently envisaged. Do we have collectively the capacity and right skills to support it, do you think?
No, not at the moment. We don't. In the 80s, there was a big hospital building programme that fell away in the 90s. Then in the late 90s and early 2000s, we had the PFI programme, which delivered a large number of hospital facilities. It's been really 10 years again since we've had a concerted effort to refurbish or redevelop new hospitals. So you know, I've been around the NHS for nearly 35 years. So a lot of my colleagues who I trained with in terms of hospital planning, hospital developments, like me, are coming to the end of their careers. There are people coming behind us, but in terms of building 48 new hospitals, making sure that we've got the right client side expertise. So within each NHS trust, within the design teams, because again, there hasn't been that many hospital projects at scale undertaken over the last few years. So making sure our design teams like David's at Stantec and others are skilled in hospital refurbishment and redevelopment, and also the constructors. And that, I think, at the moment is where the big gap is for everyone. We only now have probably about 4 or 5 very, very large building contractors who can tackle projects at scale. Now, I know the new hospital programme is looking at their commercial strategy at the moment, but that's going to take some time, I think, to work through so that there is capacity and capability in the supplier market as well as in the client market. So the answer to the question easily is no.
No. David, I'm just wondering your thoughts and whether you agree with Duane, and also are there any current sort of global trends for healthcare development which perhaps provide some valuable lessons for us as far as the National Hospital Programme goes?
I do completely agree with Duane. You know, having been part of the PFI generation of schemes here in the UK, I mean, there was a very healthy density of people, both designer, you know, client and builder alike, with you know, great experience doing these large complex projects, and it's not to be taken lightly. And you can't do any of these things without undoing certain critical connections on an existing health campus. And having that awareness and experience is really, really difficult to overcome right now. We are seeing, it's ironic, but both Canada and Australia also have significant investment plans underway right now. A little bit more matured in the sense that they've been ongoing for 5 or 10 years. They both have adopted sort of an evolved PPP model, which was sprung in the UK, and they've developed that and really modified them to increase the amount of early contractor input to try to tackle the problem that Duane's talking about, the kind of gap between the energy transfer from the hospital to design team and then ultimately to a builder. I mean, making sure that pathway is very, very fluid and self-informing. I think that's probably the biggest key thing. How the National Hospitals program will unfold is unclear to me because of the gaps that Duane is pointing out, and it's very, very difficult, particularly for the estates themselves.
Iain Smith, I've got a question from the floor for you, but do you want to add anything to that before I put Martin's question to you?
No, not other than to say that I totally agree with Duane and David that there are big gaps, particularly around the understanding and development of brief and getting that right at the very start.
Great. I'm going to put this question, Iain, to you, if that's okay, from Martin. He wants to know how the panel sees the role of modern methods of construction in the future of NHS developments, particularly the opportunity that modular buildings might offer for standardisation of compliant net zero carbon ready buildings. Any thoughts on that, Iain Smith?
Yeah, it's a very interesting area. And of course, NHS, Iain and I have stipulated that we will own the new hospital will be 75% MMC, which is a great target. But it does require the two things that Duane mentioned. It needs the industry to be able to deliver. But more importantly, it means that we need to get the brief and the design right at the start. And we can't be making changes as we go along. It really adds focus to that. And I think modern methods of construction are great. They should deliver more quickly on site, but you've got to look at the whole end-to-end process and see whether that's you're getting the benefits there as well.
Great. Let's move on. Iain, in Berkshire, Iain, can you tell us about the new Devizes Health Centre, which is under construction? I gather that's going to be a net zero operation.
So that isn't one of mine, I don't think.
That's not yours. Have I got that wrong?
Well, we might make a sort of a move towards that part of the country. I don't know.
Where have I got that from then?
I don't know.
Oh no!
Can I pick up, Helen, though, just about what you were just saying there as you get your questions? Because absolutely, I completely agree with the other Iain around the importance of technical and the question that came out around modern methods. And it's great to see any innovation coming through from industry or indeed elsewhere. And ensuring that clinical model, that service model, is at the heart of the design process, fundamental. One other thing I'd just like to flag, though, is change management. And I think personally, again, after a little bit of experience of this over the years, that it's something that we don't always pay enough attention to. And perhaps we think, let's worry about design, let's worry about the clinical model. What we don't always then do is think about how we are going to move staff physically and in terms of their approach to work from one model to another one, to a different form of working, whether that be administrative or indeed clinical. And there's a lot of research to show that projects that really develop a detailed change management strategy have a much better chance of achieving the benefits that they want to realise. So I think we sometimes, in terms of projects and programmes, are guilty of focusing on that design, making sure all those technical bits are right, but we don't necessarily then spend time with the folk who are going to use the building and being deployed with the building to make sure that they're going to use that building to its fullest extent, enabling the way that people want to work going forward.
Brilliant. Thank you very much, Iain. Martin, do you think that integrated care systems will change the way that construction and refurbishment projects are delivered and managed?
I think that will. As the colleagues have said around modern methods of construction, you know, the new hospitals are in the community, a part of the ICS, and as I mentioned earlier, it becomes a bit more of a collaborative. So it's making sure that each organisation has a proper strategy of how they want to deliver services, and it needs to be interlinked with those ICSs. So the way the buildings will be designed will again be multifaceted. We need to support primary care, so we create a proper care pathway for service users. So it can eventually be maybe a one-stop shop in the right location, designed and built, future-proofed, as you know, that prepares for a future pandemic. Hot desks is another thing that's emerged over the last 18 months. The way people are using office space very differently. So you think around IT systems. You know, is there some way we can have a more consistent and consolidated IT approach, so people can just drop in, pop their laptops in, and it's one single IT system? The way desks are booked. So there's a lot of infrastructure that needs to be considered if we're using buildings in a more collaborative way, because at the moment they are quite insular. You know, I could speak to all four of my colleagues, and I bet we've all got different ways in which we book desks, how we use buildings. So I think if we start at the ground up to think about how buildings are used, then that informs the design, and they're far more collaborative. It can only benefit the patient, because if, you know, NELF themselves are a community trust. We work closely with those acute trusts, and if there's a proper pathway that steps down from acute into community and if necessary back up, but the design of buildings can accommodate that. So I think it's really thinking about the design stage, how those buildings are going to be used and future-proofed.
So important. And Iain Smith, how can we make sure that we build bigger, better, faster, but still deliver value for the NHS?
Yes, that's the $64,000 question, really.
No pressure there, then.
No pressure at all. I think modern methods of construction have got a big part to play in that. But I also think that we need to be slicker in our approvals process, and that's where a lot of the time is taken up. And once we get on site, actually, it's that in some respects is the easy part. It's getting to that point, and I think all the things that were said before, getting the brief right, getting the design set early, working with the industry, because I don't think the capacity is there at the moment to deliver really modern methods of construction off-site buildings at scale. And if we're going to do that, we need to gear up and give the industry the opportunity to invest to deliver against that.
Duane, I'm going to give you 30 seconds because you were nodding there, and then final word to David because I'm out of time. So don't get me into trouble timing-wise, Duane.
I think the modern methods of construction thing is absolutely right. Key to that is standardisation. We've always been really quite good at standardisation in the NHS in terms of standard spaces. We just need to be a little bit more rigorous about that. I would contend that modern methods of construction, certainly in terms of that standardised build plus standardised mechanical and electrical engineering systems, has been done for over 20 odd years in the NHS. It now comes back to standardised grids more than anything else, it would appear. So it's just finding the right mix of constructors and contractors to actually deliver that. But it's also then the supply chain that sits underneath that as well, to be able to ensure that we've got a standardized set of products to put into those buildings once they're fabricated.
Absolutely. I'm just going to end on Edwin's thoughts and get you to react to them, David. Edwin says flexibility in the design and construction of NHS buildings is key, especially in acute. The design will likely be out of date by the time the project's delivered, as clinical pathways, technology and expectations change. There's much more to MMC than modular. Just a last thought for us, if you would briefly, David, and then we have to move on to our next speaker.
Well, there's about an hour of response in that question.
Yeah,
but,
I know. I realized that as I read it.
I think one thing that the designers and the hospitals alike have been working on for a long time is making sure that it's not just about flexibility, it's agility moving forward. And getting the brief is absolutely paramount. But we already try to be very predictive, to anticipate the technologies that are going to be coming 20, 30, 40 years in advance. And that really comes down to the grid that Duane was talking about, and making sure that we have a spatial infrastructure that will absorb those changes over time without triggering consequential changes in the physical infrastructure of the building, whether it's mechanical systems, building systems, most in particular. And so I think that the industry is pretty well equipped. It's a huge key design driver from the first day. But it might be that in the interest of resiliency, that we start looking a little bit beyond that. And what will these buildings be in a future state when they're not even delivering care, for example, which is also an opportunity.
Brilliant. Thank you very much for doing your hour-long answer in about 1 minute. So that was much appreciated. I'd like to say a massive thank you to our panelists. We've covered so much already this morning with the help of our guests, and we're only just getting started. So next up, we have a keynote speech from Luke Fisher, Head of Marketing at UVCABINET. Luke will be discussing UV products for shared devices and whole room disinfection, which is very topical. So I'll hand you over to Luke.
Lovely, thank you very much. Just to give you a bit of background, UVCABINET Limited we're a leading supplier of UVC disinfection products and part of the Emotion Group PLC. We already supply to the NHS, supply our cabinets to the NHS, and today I'd like to talk to you a little bit about the technology behind what we do and take you through our new CLEANROOM whole room disinfection system, which hopefully you'll find interesting in the context of what you've been talking about this morning and will be talking about later. So we're a company who's committed to helping organisations control cross-infection in the most effective and efficient way, but paramountly and always in a completely safe way. Next slide, please. So a little bit of the background. UV, or ultraviolet light, is a spectrum of light that's generated by the sun, as I'm sure you know. And most of us are familiar with UVA and UVB, the radiation in the sun that gives us suntans, etc., and can burn. And all of those UV things have some germicidal effect. Now, UVC is a part of that spectrum which is it does not reach the earth. Basically, it's blocked by the atmosphere, but it's many thousands of times more germicidal than either UVA or UVB, and optimally so at 254 nanometers. And that's the wavelength we use in all of our products to act as a germicide. And it operates by acting directly on microbial DNA. And it basically disrupts the DNA, it prevents them from reproducing, and it kills typically 99.99% of bacteria, viruses, protozoans and spores, and depending on the application, in as little as 2 minutes. So also UVC is extremely harmful to humans, can damage skin and eyes, which is why safety is absolutely paramount. Next slide, please. So CLEANROOM is our whole room product capable of disinfecting surfaces and all of the air, and it kills, as I said, 99.9% of all viruses and bacteria. It's a product which is suitable for retrofitting into all sorts of rooms, but it's also possible to build this system in from the start. So it can be planned into a new build and become part of the overall system for reducing cross infection. Next slide, please. So the way the system works is that we use fixed UVC light sources, and we audit the optimal position and number of lights to ensure that you get the maximum coverage and efficiency. There's no need for chemicals, chemical wipes or sprays, and there's very, very fast turnaround of critical rooms such as clinics and operating theatres. In as little as 10 minutes, you can completely disinfect all the surfaces and the air in a room. It's also extremely safe to use with sensitive equipment and electronics. And we've done extensive testing on that, running the equivalent of running it for many years with electrical equipment. and, as I say, can disinfect the entire room, including the air. Next slide, please. We've designed it to be simple, to be fast in use. It can be programmed to run completely automatically without human dependency, and it's programmed by an app on a tablet or a smartphone, and it features full traceability, and that means evidentiable disinfectant. It will report all the times that it's had a cycle, it will report interruptions, etc. And it's very cost effective because it removes manual cleaning and also expensive consumables from the process. It's almost maintenance free. Really, the only maintenance that's required is that the bulbs need replacing after several years of use. So effectively, once you have it installed, it doesn't need touching for many years. Next slide, please. Cleanroom is effective on all surfaces and exposed equipment. And depending on the choice of lighting, the intensity of the lighting for the application, it can disinfect in as little as 10 minutes. And our controllers can support multiple rooms, meaning dependable cleaning across many locations, all controlled from one centre. It significantly reduces downtime, it reduces manual cleaning, and it saves money, time and money. Next slide, please. For us, the absolute key to any utilisation of UVC is safety. UVC light is extremely dangerous, and even limited exposure can be very damaging to the skin and eyes. We have an unrivaled presence of life detector at the heart of the system, and it detects life even when it's motionless at up to 15 meters away. And it's calibrated to the specific space. And in larger spaces, you can have multiple detectors that can work in concert across a large area to ensure that there's absolutely no chance of anybody human exposure to the UVC source. It simply can't happen. The other thing is that our specific UVC light sources do not produce any ozone, and ozone is often a byproduct of UVC bulbs, and that in itself, in even very small concentrations, can be extremely dangerous. Next slide, please. Cleanroom is also smart. We've designed the system around a unique controller that connects by wire to the UVC light sources and by Wi-Fi and the LAN to our control app. The system can be programmed to be fully automatic and uploads completed cycles, interruptions, and even when to change the bulb to the app through the cloud-based system. It's a completely self-monitoring system. The system is constantly checking itself, scanning components to make sure that it runs optimally, and will immediately report any faults. And the app can run just on any Apple or Android tablet or smartphone. The tablet also acts as the warning panel and status indicator, and it can be mounted outside at the point of entry. And as I said before, multiple rooms can be remotely controlled from one place. Next slide, please. So what makes a clean room? It's a fairly simple array of high intensity UVC light sources. They can be installed by any qualified electrician. Typically for a standard room, you'd have 4 double tube light fittings, a presence detector, which is usually again situated in the center of the room, and that connects through wire to the smart controller, and the smart controller acts as effectively the brain of the system. That's the conduit for switching the lights on and off, receiving information from the presence detector, and also talking to the app and making sure that the programs are both enacted and also the operational things are reported back to that. Next slide, please. So in terms of how it works in practice, particularly if you're retrofitting this system, is that we will audit the room, and this is something that can be done from drawings, from dimensions, or in person with a visit or basically remotely via Zoom, etc. And with that, we have software where we can plan the optimal array for that space to make sure that all the surfaces are adequately covered. The system's then installed, and as I say, so self-installation is very straightforward as a retrofit, and clearly if it's part of a new build, it can be planned in. It's very simple wiring that goes back into a junction box that's then controlled by the smart controller. It can take as little as an afternoon to install a system. And then once that's there, there's a very simple setup procedure of connecting the app and the system, and it's then programmed and it's ready to go. And it can just be, it could be run fully automatically if necessary. Next slide, please. And as a case study, the first clean room that we installed at the University of Chichester, they had an issue with their teaching audio studio, which has got a lot of very complicated equipment, very expensive equipment that was extremely hard to clean, and was meaning that every time they used it with students, pretty much an entire afternoon had been wiped out with the cleaning process. And also they didn't like using chemicals on such sort of intricate machinery. So we've installed this system. It has revolutionized the turnaround in the room. It means that they can undertake the teaching, and the moment the session is over and the doors close, the system comes on, and 10 minutes later, the entire room, all the air, every single one of the intricate circuit equipment has been cleaned, and it's ready to use. And it's meant that instead of having really one teaching session a day, they can now have multiple teaching sessions and get absolute best use from that. Next slide, please. The second set of products that we already supply into the NHS, but are an excellent means of reducing cross-infection when you're planning into a building, is our UV cabinets. They're a safe and effective way to basically sterilize shared devices. They use the same proven medical grade UVC lights, and they ensure an all-round surface disinfection in just 2 minutes. Next slide, please. They are extremely safe. They meet all the industry standards, and we have full laboratory third-party testing for them all. No UV light can escape the cabinets. No ozone, again, is produced, which is particularly important if these are in enclosed spaces. And all of the cabinets have complete automatic shut-off. If you open the door, the light immediately goes off before you've even got a crack in the front of the door. Next slide, please. They're very simple to use. You simply load up the devices to be disinfected, close the door, and press a single button. And within 2 minutes, all of those shared devices have been disinfected. You can also completely program the amount of length and, in fact, the light intensity if you have a requirement for a higher log, for example, of disinfection for certain things, or a more complicated surface profile. Next slide, please. So the cabinets don't simply disinfect. They have internal fast charge USB. It means that many devices, up to 30 in fact, can be charged at once, and the largest cabinet we have can accommodate up to 100 smartphones or 75 tablets. So they have a huge capacity and ability that if you're in a busy environment and you want to get things sterilized, they can be loaded in. 2 minutes later, they're completely disinfected. But also, if you leave them in there, they will continue to charge. And if you want to secure them, it has full locking secure construction. In fact, the whole thing itself is built much like a safe. Next slide, please. They also feature very sort of strong and lockable wheels, so they're mobile. So you can move the cabinets around wherever you want to within the hospital, and they all operate from a standard 240 volt plug socket. They're designed to be compact, so they will go under pretty much any standard desk or countertop. And as I said, they're completely safe electrically and from a UV exposure point of view. Next slide, please. The cabinets are available in 3 sizes, small to large, and it basically means that you can store from 30 to 75 tablets in them. And it really just depends on the type of application, the workload that you need to put the cabinet through, as to which one you choose. Next slide, please. And in terms of where we're currently, so we sell these products across the world into all sorts of industries, including healthcare. In fact, we are a supplier, as I said earlier, to the NHS, and we've had experience where this has dramatically changed the way people have been able to do tasks during the pandemic, particularly through some VR simulation training in the NHS, where previously it was just too tricky to mechanically clean enough of the headsets to get the training done. And we're continuing to supply large numbers of these cabinets into healthcare, both here and in the United States and Australia. Next slide, please. So thank you for your time. I hope that's given you some insight, particularly into the clean room product, of how that can be integrated as part of reducing cross-infection in hospitals and clinics. Please do visit our virtual stand. And we have there quite a lot of literature, both on the science and also on the products, as well as a couple of videos for you to watch. So thanks again for your time.
Well, thank you, Luke. A lot of information there, and I think you've really captivated the audience with what's possible in terms of disinfection. So thank you very much for your time. It was lovely to have you with us today. Let's catch our breath and take a short networking break, perhaps just 6 or 7 minutes. This is your chance to grab a rest from the screen, perhaps digest some of the valuable things we've heard already, or jump into our speed networking tools to start some dialogue with your fellow delegates. It is 11:29 now. Let's see you back at 11:35. Cool. You hop me into the next bit. See, we've got 6 minutes break. Marvelous.